Good morning. I just want to begin by thanking Dr. Wittig and all of my colleagues and his assistants for putting such a great conference together. I get the joyful experience of giving the talk just before lunch, when most people have one foot out the door, and I give the first talk after lunch, so I can see you all have your afternoon nap. But in fact, I don't have the last talk. I just want to let you know there is a change to the schedule. Right at the end of my talk, there's going to be a 10-minute video on injections given by Dr. Siegel. So I'd encourage you to stay at the end of my talk to watch that video. My name's Wayne Colizza. I'm one of the joint replacement surgeons here. I'm also a sports medicine physician and have served as chief of sports medicine for many years here, and now I'm the section chief for joint replacement. And I confine my practice to surgery of the shoulder, the hip, and the knee, and I'm a practice partner at Tri-County. So I'm going to talk about a difficult problem because even though I entitled it osteoarthritis of the hip in the young athlete, it can very well be extended to osteoarthritis in the young adult because many of the same issues are present. So before I even get into this, and I don't want to repeat what you've heard already, but you truly have to evaluate the source of the hip pain. And this has been gone through by Dr. Cilia very, very nicely, but excluding internal versus external causes of hip pain, appropriate investigations, and come up with the correct diagnosis. And just to reiterate what's been said already, I hear groin pain, orthopedically I think hip. I'd say maybe in 10% of my patients is hip arthritis present when they have gluteal pain or lateral pain to the hip. It's in the groin, that's what we hear. And education is very important, so I'm going to talk about the patient who has hip arthritis and has had all of the non-operative measures available for hip arthritis, and they no longer work. So they're at end-stage arthritis and are a candidate for a surgical procedure. So what do I hear about when I talk to patients about hip arthroplasty? Well, first and foremost, they only last 10 years. You know, they say it takes 1 minute to put an error in a textbook and 50 years to change it. That's just not the truth. And you can look at this throughout the orthopedic literature. Hip replacements as a whole do not last 10 years. They last much, much longer. And it's truly an excellent operation. And Dr. Lombardi alluded to that earlier, and I will tell you that if you look in quality of life years and surgical procedures, I believe that hip replacement is number 2. Hip precautions last forever. They do not. And hip precautions are short in those patients who have a posterior approach, if they have hip precautions given at all. And there's certainly no hip precautions in anterior approaches. And patients come in and they say, I'm too young. Well, that may be true because the younger you are, the greater the possibility or probability that your replaced hip may fail and you'll need a second operation. That may be true, and it is true, but when you are failing hip, and you can't put on your socks and shoes, you can't get in your car, you can't do anything with your kids, or you can't do any of the activities you enjoy, it really doesn't matter how old you are, because life is not fun, and those are the patients that I'm talking about. So what do I worry about when it comes to hip replacement? Of course I worry about age, because if you're younger, you have a lot of years left. I'm interested in knowing your activity, because with a standard hip replacement, you can't do everything. You can't be a marathoner, ideally, and we'll go through that. And what are your expectations? It's an excellent operation, but it may not meet what all your expectations are. I worry about things wearing out. That was a problem early on in hip replacement because the wear of the polyethylene liner was a problem. We don't tend to see that today because the polyethylene liners are highly cross-linked and their wear characteristics are dramatically improved. So wear really isn't the primary cause of failure. In fact, it's quite far down the list. I worry about dislocation, and that has to do with activity. And I worry about loosening, because that's really become the number 1 cause of failure after 2 years in joint replacement. Early failures are dislocation, number 1, and secondly, infection. After 2 years, the number 1 cause of failure is either loosening, of the acetabular component or loosening of the femoral component. This is an old graft, but it's from 1993. It's from the Journal of Bone and Joint Surgery, which is really considered our Bible. It was an article by Jossie who looked at Charnley hip replacements. John Charnley was the original designer of the hip replacement, the father of hip replacement surgery in England in the 60s. And they looked at young patients, 50-year-olds, who had a hip replacement. 20 years later, almost a 50% failure rate. It was not a good operation. So what were patients told? Hold off as long as you can. Easier said than done. Take non-steroidals and all the complications that can come with them. Live with your pain and disability, or undergo what was considered a premature total hip replacement. Clearly a problem. Here's an article a little closer, 15 years ago, 2004, from Clinical Orthopedics. Failure rates, all causes, for a non-cemented total hip replacement. If you were under 50, you had 11% failure rate at 10 years and a 40% failure rate at 15 years. That's really high. If you were under 40 and had a conventional hip replacement, 15% failure rate at 10 years, 46% failure rate at 15 years. So we needed to improve upon this. This is Derek MacMahon. Derek MacMahon is a orthopedic surgeon out of Birmingham, England. He took on this problem back in the 1990s, and he designed what's called the Birmingham Hip Resurfacing. It's named Birmingham because that's where it was designed. He took on the problem of young active patients with severe hip arthritis, and what was his goal? Design something that allowed a pain-free, stable, mobile hip. Give it longevity. Make it easy to revise if it should fail. And allow patients with this joint to have unrestricted activities. He designed the BHR. It's been used globally for over 22 years. It only obtained FDA approval here in the United States in 2006. I did the first one here at Morristown in 2007. I've done the most in the state. I'm not the only one who does it. Paul Lombardi also does resurfacing. So this procedure is available here in Morristown. International study, almost 17 hips, satisfaction rates of almost 99%. This is a conventional hip replacement. You look at the hip on the left, look at the second diagram, you see that the femoral head and the femoral neck have been removed. You then take a femoral stem, put it down inside the femur on the last picture, put a head on the stem, put a polyethylene liner in and an acetabular component. So you remove all of this bone here. How is a BHR different? Well, you don't remove this bone. You preserve bone. Very important in a younger individual. You shape the head to accommodate the femoral component, and you don't cut the neck. So this is the final product. It's a femoral component on a acetabular cup without a liner. So again, conventional hip replacement, bone is gone. Birmingham Hip Resurfacing, it's preserved. This is what it looks like after. You can compare this to some of the x-rays you already saw, where you saw this stem down the femur. So what are the advantages of this hip resurfacing? Again, minimal bone resection, normal femoral loading and anatomy. You're not changing the anatomy. The angle of those femoral stems are fixed. They don't vary. So you're maybe putting in a different angle than what exists normally in that individual. The resurfacing mimics that, restores normal anatomy of offset, leg length, and anteversion. In every resurfacing I've done, I've never had a limb length discrepancy, never given a lift. There's minimal risk of dislocation. Easy revision. Why is it an easy revision? Because you can just cut the neck like you do with a total hip replacement and then put a total hip replacement in. You do not have to disturb that femur. There are some individuals where they have a failure of the femur and we have to do what's called an extended trochanteric osteotomy. Actually cut the femoral bone, open it like a book, to get that stem out. That's a pretty complicated revision. But the biggest advantage here is unrestricted activity. And by unrestricted activity, I mean unrestricted. I have marathoners in my practice. I have people do everything. Parachuting, play contact sports, no restriction. Well, that's nice. Where's the proof? The proof is in the pudding. Now, we can look at all the studies that are out there that say this operation is great, or I could stand up here and say this operation is great. Well, let's look at something that's probably the most revealing of any information when it comes to surgical techniques. Let's look at a joint replacement registry. What's a registry? Every single joint done is recorded. Every joint that fails is recorded. Now, we are really in the infancy of doing a registry in the United States. There are some registries available. We participate in. Dr. Darling started our participation in our registry, but not everyone participates, not every medical center. A countrywide registry through the academy is in process. So we really don't have one with any legs. But Australia does. It's the most comprehensive, oldest joint registry in the world. It's almost 20 years looking at joint replacements. Every single joint in that country is tagged, and every single failure is noted, and all outcomes are noted. That would change, of course, if somebody from Australia happens to move to New Zealand and has a revision there. So there is some loss to follow up. But this registry is extremely comprehensive, and you can't hide. So let's look at the percent revision of total hip replacements, conventional total hip replacements, by gender and age. If you look at males, at 17 years, 9.6% have been revised. So at 17 years, the failure rate is less than 10%. If they're less than 55 years of age, they're young, 10.5%, obviously higher. And as you get older, obviously lower, because you're not around, and you're probably less active if you are. Females, actually a little better underage, actually overall better at 8.7, but slightly higher in the younger ages. That may be due to bone quality not being as good, maybe more fractures in females. We certainly see that in total hips. What about hip resurfacing? Again, overall, 9.7% failure rate, 0.1% worse as a group than total hip replacements. Pretty much identical. But what about under 55 years of age as a male? 9.7, same, 8.6 as you get older, pretty similar to total hip replacements. Females, however, do much worse with resurfacing. And we know why. It has to do with smaller head sizes and bone quality. Consequently, and unfortunately, I don't do resurfacing in females. We did originally, and it's because of that take-all-comers and registry information that we realize that women do not do as well. But let's look a little closer at the data. And this is the last table I'm going to show you. Percent revision of primary total resurfacing hip replacement by gender and head size. If we look at less than 50, at 15 years, the failure rate was 14.4. But if we look at males with a head size greater than 50, cumulative failure rate at 17 years is 8.6. 10.5 for hip replacement, 8.6 for resurfacing. So there's almost a 20% less failure rate of hip resurfacings done in males with a head size greater than 50. Is greater than 50 an unusual number? No. I would say that 90%, if not higher, of all males have a head size greater than 50. So it's rare. I don't even recall finding a head size in a male less than 50 that I've operated on. So a 20% less failure rate than a total hip replacement at 17 years. Pretty remarkable numbers. If you look at the female with head size, less than 50, 1 in 4 failed at 15 years. Can't do it, unfortunately. So let's compare the two. So I'm going to take a select population. I'm going to take that active young male athlete, for example. But I could also apply it to a non-athlete who happens to have a head size greater than 50. 17-year revision rate of 8.6, actually 10.5 with total hip replacement. Unrestricted activity, easier revision, and restores normal anatomy. So, what can we do after a total hip replacement, and where did we get this advice? Well, there's not really a whole section of papers out there talking about what you can do and can't do after hip replacement, but most of what we do and most of what we tell our patients is actually based on consensus. There have been these large surveys done of members of both the Hip Society and the American Association of Hip and Knee Surgeons. This was done once, many years ago, and then revisited, I believe, just around 2007. So what was the consensus? You are not allowed, with a hip replacement, to do racquetball, squash, jogging, contact sports, high-impact aerobics, baseball, softball, and snowboarding. Can't do it, not recommended. This is an association pretty much of all the hip replacement surgeons in the country. What will you allow with experience? Meaning if you were a downhill skier and loved the moguls before, I'm going to be more inclined to allow you to ski the glades and not the moguls after your hip replacement because you have experience in that sport and less likely to have a traumatic injury. So we will allow with experience downhill skiing, cross-country, weightlifting, ice skating, nothing impact. And we'll allow all of these other much less impactful sports for anyone who has a total hip replacement. American Journal of Sports Medicine, 2007, Sports After Hip Resurfacing Arthroplasty. Interesting article, but it's a level of evidence for. Doesn't carry a lot of weight with me, but nonetheless, 110 out of 112 with a resurfacing return to sports. This is Fisher et al. From Orthopedics in 2011. 117 patients. What's their age? Average 54. These are young patients. Follow-up 2.5 years. 87% return to sports without fracture or dislocation with a resurfacing. This includes football, squash, jogging, hiking, cycling. Some of these pretty impactful sports. Last article, Fouleron, American Journal of Sports Medicine, 2012, Prospective Series, case series. 215 patients with a resurfacing. 33 out of 40 runners resumed running at 16 weeks post-surgery. 23 of them, 3/4 of them, were running more than 4 hours a week. 82% resumed high-impact sports without osteolysis or bone loss, loosening, or revision by almost 4 years. Here's a couple of people. Scott Tinley, Ironman, hip resurfacing. Floyd Landis, a little bit of infamy with that name, but nonetheless, he competed in the Tour de France with a resurfacing. So my advice to all patients, I offer resurfacing to all male patients under age 65 with a femoral head size greater than 50. Why? Because I want to preserve their bone and I want them to be able to return to sports. And all athletic males, regardless of age. I have some master athletes who are much older than 65, want to get back to their running or doing their sport. All others, including females, I offer a total hip replacement with an alternative bearing surface. Total hip replacement, I tell my patients, sorry, no running, no impact or contact. Some sports with previous experience. BHR, I don't care what you do. I do a posterior approach for BHR because it's been tried to be done anteriorly. You cannot. It's too difficult an operation because you actually have to expose the head to put the prosthesis in correctly. Very difficult to do. Any questions? Dr. Dowling, what's the cost difference between a BHR and a total hip? Do you know the numbers, or Dr. Wittig? I think they're in the same ballpark, are they not? Because we're all capitated, right? Whether it's, basically same price. Sure. If you read the New York Times and you read other things, you may have encountered over the last 2 years a lot of issues with metal on metal. This is a metal on metal component. There's different aspects of metal on metal. First and foremost, metal on metal hip replacements. There's different types. There's metal on a metal socket. There's a metal socket with a metal insert with a hip. These have developed and been highly scrutinized by the FDA because of population of patients getting what's called a metal-on-metal reaction related to these components. There were a number of different resurfacings on the market worldwide. They're gone, every single one. The only one available in the United States is the Birmingham hip. Why? Very different metallurgy, very different geometric design. The FDA has had 0 issues with Birmingham hip resurfacing. There's been no recalls, there's been no comments on BHR. Why? Because of the data I showed you. If you're going to have a failure because of metal on metal, it'll be reflected in those numbers. If you've had a dislocation, if you've had a fracture, if you had an infection or a loosening, all of that's going to be reflected in those failure rates. Those failure rates are lower than a total hip replacement at 17 years. So I'm going full steam ahead with this based on what is some very concrete data. Any questions? All right, there's going to be a thank you. There's going to be a video now. Dr. Jeff Siegel, thanks.